The chair is Grace Elter, the co-chair Peter Cotton, and they've been moving along very well with their committee and are well advanced. The key disorders in this group of functional diseases, if one can say that, is firstly the functional gallbladder disorder or disorders. Secondly, biliary sphincter of Oddi dysfunction, SOD. And thirdly, sphincter of Oddi dysfunction and the relationship to the pancreas, particularly idiopathic recurrent pancreatitis. There have been some changes. I won't go through the criteria for each of these. I don't think it's quite as relevant in this forum. But there are some changes that will impact on practice. Pick up a few changes such as I've mentioned here. There's certainly more emphasis on the questionable value of the CCK cholecystography or the quantitative biliary imaging that's available to us in these disorders, particularly its role in the functional gallbladder disorders where obviously the gallbladder is intact. You may be aware of this current recommendation where the ejection fraction of the gallbladder lies somewhere between or below 30% or 25%, and that's said to be an indication for cholecystectomy. The question is how reliable this has always been a problem, and there's discussion on the committee what to do with this, whether one may be able to move towards cholecystectomy without this condition, as long as the patient may satisfy the rather strict criteria for biliary type pain, which I won't have time to go into. The second point is that when we come to the biliary sphincter of Oddi dysfunction, a difficult problem, as I said, in some patients who undergo cholecystectomy and exhibit or develop recurrent abdominal pain similar or almost identical to what they experienced prior to their cholecystectomy, even if that was undertaken for gallstone disease. And we've been using the old Milwaukee classification so far, types 1 to 3, which largely deal with a number of objective criteria, at least in types 1 and 2, moving to the lack of objective criteria in type 3, and based on some recent clinical trial work, which is still to be published, undertaken by Peter Cotton and the other investigators. It does seem that type 3 may longer be viable, and this was always the difficult patient group, of course, where there were no objective criteria, and yet some were still subjected to perhaps invasive sphincter of Oddi manometry and even sphincterotomy. And thirdly, there's been some re-evaluation of the so-called dual sphincterotomy, which was cutting the biliary segment of the sphincter and the pancreatic segment of the sphincter in someone who may only have sphincter of Oddi dysfunction that has biliary type symptoms, or someone who has sphincter of Oddi dysfunction with only pancreatic type symptoms. And that was probably rather unnecessary to be cutting both those sphincters. But this is still work in progress, and we'll see what develops. But I think these are certainly changes that will have impact on clinical practice and investigation. So, 3 more contentious issues that are being dealt with, partially dealt with. We needn't go into these in detail, but there was always a subgroup of patients who have biliary pain and the intact gallbladder that seem to have some features that may also suggest sphincter of Oddi dysfunction. And the question still remains whether to evaluate the sphincter first prior to cholecystectomy. But it's probably going to be that one still may undertake cholecystectomy first if it's indicated in this group. We've discussed whether it's worthwhile doing this biliary scintigraphy or perhaps another manoeuvre in the diagnostic algorithm of SOD. Well, we discussed it actually for the gallbladder ejection fraction, but it's also contentious in SOD, where it can be used to perhaps indicate malfunction of of the sphincter with a paradoxical contraction to some provocative testing. But that may also have some impact on clinical practice, because we're very much searching for some non-invasive diagnostic testing for SOD rather than relying on this invasive sphincter of Oddi manometry. And then the whole question of atypical biliary pain is being debated. This is a very difficult area in practice, and one always likes to see, when one's considering these patients, typical biliary pain, which can be defined, although there's not a lot of evidence for that definition, but it's withstood the test of time. We'll see what comes up with atypical biliary pain.